Well, today lecture is on acute cardiac syndrome investigation and management. And the speaker we have here is Dr. Debojyoti Dutta, who is a consultant critical care medicine in Fortis Hospital, Anandapur, Kolkata. And we also have a moderator. It is Dr. SAUREN Panja, who is head and senior consultant at Narayana Health Rabindranath Tagore International Institute of Cardiac Science in Kolkata. Thank you everyone to be here. Thank you, sir, for being with us. You may take over.
Good evening. Thank you, Sana. Good evening, everyone. So, as already we started, our discussion topic will be acute cardiac syndrome. Mostly, we'll focus on the acute coronary syndrome. So, the whole of the discussion will be pretty little long. So, try to be with the, the whole process, whole time actually. So, I'll start with a little bit of introduction. So, as you all know, the CVD, cardiovascular disease, is the most common mortality and morbidity in the worldwide, and it's mostly prevalent in the low and middle income countries, most of the cases. And the highest burden of ACS among them, all the CVDs, the highest form of CVD is the acute coronary syndrome. In Indian scenario, if we come to that, the STEMI is much more in Indian scenarios as compared to the Western countries, and 30-day mortality is also pretty high with compared to the Western countries. And majority of the patient in our scenarios receive the thrombolysis, though the data is little older. So, so it is a create registry which has given us this data. Here we can see that the most prevalent in Indian scenario is STEMI, and our primary modality of therapy was at that particular time was fibrinolysis, and the mortality is also higher compared to the global registry and the other Western countries. Though the data was pretty old, maybe in after that it has improved. So first we start with what is an ACS. It's a spectrum of condition that is compatible with acute myocardial ischemia or infarction due to an abrupt reduction in the blood flow. The coronary blood flow will be reduced abruptly, that's leading to the ischemia or infarction depending on the severity of the blood flow reduction. Here is a two entity in coronary syndrome. So one is a stable and one of the acute unstable. So what is the differentiating pattern from it? It is occurring at rest occurring in rest or with minimal exertion, usually lasting more than 20 minutes. It's just being severe and of new onset chest pain or chest discomfort will start and occurring in a crescendo pattern. That is very important. The more the time goes, the severity of the discomfort of the pain will increase. This is a diagram. Here is a basic pathophysiological mechanisms of ACS. So here we can see in the left hand side, there is a supply demand mismatch, and the right hand side is an acute coronary syndrome. What's happened normally in our coronary arteries, there is a plaque formation is already there in some of the patients. When this plaque is present, the lumen get narrowed. So the supply of the blood to the coronary arteries is not normal, though the coronary myocardium is barely managed to withstand that. But when there is a demand supply mismatch, it leading to the ischemia, which is evident as a ST depletion in these cases. But if the plaque got ruptured or erosion happened, so they are leading to the secondary thrombus formation. After this thrombus formation, in these two images on the right hand side, you can see that it can partially occlude the whole artery, or it can completely occlude the whole artery. If it completely occludes, that's leading to the complete disruption of the blood flow to the distal myocardium, which is evident under the ECG as a ST elevation. On the other hand, partial obstruction as a ST depletion. So these are the ECG findings. Now, if we do the serial biomarkers, this disruption leading to our myocardial injury. The myocardial injury marker is our cardiac troponin levels. If it is increased, it means there is a myocardial injury or infarction has already happened. So if you have someone having a ST elevation with the increased biomarker, it will be termed as STEMI. Someone is with ST depression with an increased biomarker, it will be called as a non-STEMI. And which is a ST depression without any biomarker level changes, it will be called as an unstable angina. This non-STEMI and unstable angina, it could be because of the demand supply mismatch or could be because of the atherosclerotic plaque rupture. Based on that, it will be type 1 or type 2 MI. We will come into that later. So here is a diagram. We can see in the left hand side is the intact blood vessels, where the endothelium is intact, and below the endothelium we can see the collagen fibrils, volume factors are there on the matrix, and in the bloodstream the platelets are wandering around. When there is a damage in the endothelium, this platelet it get attached to the volume factor in the collagen, form the platelet plaque. Later on, when the coagulation factor will be activated, it will lead into the secondary fibrin-rich coagulum or the plaque formation. It will increase. If the progression of this thrombus will increase, it can cause to complete obstruction of the whole lumen or the partial obstruction. Here is a basic mechanism of the development of thrombosis. Here we can see this is a yellow one. It is a plaque core, which is made up of mostly the fat deposit and foam cells. And this thin lining of the red, it is the endothelium. In between, there are the fibrous cap. When there is a superficial endothelial injury, then platelet get activated and get attached to that, form the platelet cord, followed by it is leading to the thrombus formation. So when this thrombus formation is causing a complete obstruction, obviously it will lead to the STEMI or the ST elevated MR, or if it is the partial obstruction. Hello.
मम्मी ने बोला था मम्मी फोन देर से देख रही थी
Excuse me, somebody mute. Hello. One of the participants has not unmute.
Yes, I've done it.
Okay.
It's fine.
So if it is a partial obstruction, it will lead to unstable angina or to the non-ST elevated MI. So overall, if we see that complete obstruction leading to ST elevation and incomplete occlusion would be the unstable angina and STEMI. Besides this, plaque disruption or erosion, there are other mechanisms of acute coronary syndrome, like the coronary vasospasm, spontaneous coronary artery dissection, and embolism of the coronary artery. So, in this new guideline by the European Society in 2023, they have mentioned ACS as a spectrum. Here we can see from the left to the right, if we go, the severity will increase of the disease, and also the changes we can find it out. So grossly, if you can see, it can start with the oligo-asymptomatic to the ultimate fatal to the cardiac arrest. And from the ECG, they start with normal ECGs to the depression or elevation leading to malignant arrhythmia. And next, the working diagnosis has to be made, then the biomarkers, and then the final diagnosis. Now, one thing is very important before going into detail in the myocardial infarction. What is the myocardial injury and infarction? There is a very wide difference between it. Myocardial injury could be because of the acute myocardial leading to the myocardial infarction or may not be. So myocardial injury means when the myocardium got hit, it will release the cardiac troponins in the blood cell, and we can find it out with the biomarker. So all elevated of cardiac troponin means myocardial injury. But there are certain other conditions which are not really related to the atherosclerotic blood disruption of thrombus, so they are not an acute myocardial infarction. So there is a little difference. Here we can see the myocardial injury related to acute myocardial ischemia. This is the atherosclerotic blood disruption of thrombosis. Myocardial injury related to acute myocardial ischemia because of oxygen demand supply mismatch. And other causes of myocardial injury which are not actually related to the myocardial arterial disease, coronary artery disease directly, like heart failure, myocarditis, cardiomyopathy, defibrillatory shock, catheter ablations, and sometimes systemic conditions also cause rise in our cardiac biomarkers. So therefore, in acute coronary syndrome or acute myocardial infarction, there is a biomarker will rise, but all biomarker, if it is spectrum, here you can see in the central core, if there is a clinical evidence of acute ischemia, ischemic myocardial injury, last raised biomarker is a myocardial infarction, or else it could be something else. It may not be related to the acute myocardial infarction. Therefore, MI, if we come to the definition of myocardial infarction, there is a dynamic rise and fall of troponin. It's very important with at least one value should be above 99th percentile of the normal. And associated, there has to be ischemic symptoms or ECG changes or new wall motion abnormalities on echocardiography. The most troponin elevation in the ICU we all face may not be, does not represent all the time the myocardial infarction. That's why it should not be routinely measured until and unless it is clinically indicated from the symptomatic point of view or the ECG point of view. Therefore, the universal acute myocardial infarction definition is came where the same thing there has been portrayed like the rise and fall of the cardiac biomarkers value associated with at least one of the following, like symptoms of ischemia, new or presumed significant ST segment or T changes, development of Q waves, imaging evidences, or identification of intracoronary thrombus by angiography or autopsy. This now come to the classification of myocardial infarction. It has a 5 type actually. The type 1 is a spontaneous myocardial infarction. It is related to the atherosclerotic plaque rupture, ulceration, fissuring, erosion, or interluminal thrombus formations. Type 2 myocardial infarction, it is secondary to ischemia imbalance. It means demand supply imbalance. Most of the cases, patients have a stable coronary plaque. When the demand supply imbalance happens, leading to the myocardial injury. Type 3 myocardial infarction resulting in death when biomarkers values are unavailable. It means patient died before the biomarkers values blood sample could be drawn or before the cardiac biomarkers had get the time to rise. But there is a clinical symptoms, preceding symptoms, and ECG changes are suggestive of acute coronary syndrome. Type 4A, there is a myocardial infarction. Yeah, Type 4A, here we can see it is related to the percutaneous coronary intervention. Here, after the PCI, if the rise of troponin values more than 5 times of 99 percentile upper reference limit of cardiac troponin or in normal patient, or the already the cardiac troponin levels are higher, from there if it is rises more than 20%, associated with symptoms such as new symptoms suggestive of myocardial ischemia, new ECG changes, new angiographic changes, new other imaging modality changes. And type 4B, where the myocardial infarction related to the stent thrombosis, which is can only be found out by coronary angiography. And type 5, just like the type 4A myocardial infarction to the PCI, it is also myocardial infarction related to the coronary artery bypass grafting. Here the level is little higher. It is a more than 10 times of the 99 percentile upper normal limit, and other ECG changes, clinical symptomatic changes, and angiographic evidence and imaging evidence. So here we can see what is the type 1 myocardial infarction. This is a plaque related erosion or thrombus leading to the complete obstruction or partial obstruction. So type 2 is a demand supply mismatching. This is the whole context. This is a algorithm we can follow. If it is found a raised elevated cardiac troponin markers, if it is a troponin levels are stable, not falling or rising, it's a chronic myocardial injury. Or if it is a rise and fall is there without acute ischemia, there is no ischemic changes in the ECG symptoms. It could be because of myocarditis and heart failure. With an acute ischemic changes, now if it is atherosclerosis or thrombus related, it could be type 1 MI, or it is oxygen supply demand imbalance, it could be because of the type 2 MI. It's called the type 2 MI. So, what are the risk factors of myocardial infarction? So, here you can see the risk factors. One is the modifiable and non-modifiable. Modifiable like diabetes, smoking, hypertension, hyperlipidemia. Non-modifiable age and gender, more the age and male has a higher propensity. Family history, by first degree family relatives with higher chances of developing AMI. Minor risk factors like physical inactivity, poor diet, emotional stress, uh, addiction history, this all. Smoking, among these risk factors, smoking cessation is one of the has a most immediate effect. Giving up smoking is the single most effective contribution to the patient can make. And the goal of LDL level below 100 with a statin among other lipiding variants is one of the drugs that can reduce the mortality also. Clinical feature, how this patient with ACS presents. Characteristic pain like severe persistent typical substernal pain. Quality of the pain is very important. Dull, squeezing, tightness, heaviness and pressure. We'll come to the clinical features next slide. It is radiation. Associated symptoms like sympathetic, like diaphoresis, cool coming skin, sympathetic symptoms, and parasympathetic sometimes have a weakness, nausea, vomiting. And cardiac findings that we can get it like S3 and S4 gallop and systolic murmur if there is a structural damage by MI.
ভাত হবে না পরোটা হবে
Please mute yourself. So this is a slide presenting the chest pain or the chest pressure. Of the 80% of women and men of the with ACS present with the chest pain and the pressure. So among them, the classical chest pain that is the most indicative of the ACS, like the diaphoresis, epigastric pain, shoulder arm radiations. Others, some symptoms may be more common in women like dizziness, nausea, vomiting, jaw pain, and shortness of breath. Here is the diagram is showing the chest pain characteristic and the probability of the ischemia. You can see from the left to right. So this is a likelihood of presentation, likelihood of ischemic ACS depending on the presentation. Like if it is an increased likelihood where the chest pain radiates to the right arm or shoulder, the left arm precipitated by exertion and associated with diaphoresis. But if your chest pain is like pleuritic, increases on deep inspiration, coughing, or is sharp pain, positional pain, reproducible with palpation, less likelihood the pain for the ACS. There is a chest pain risk factor has been done over here. Based on that, we can categorize the patient and follow the next steps. So overall, if I say so, the three features of chest pain tell whether or not the pain is ischemic. Here you can rule it out. If the changes in respiration, pleuritic, changes with position of the body, changes with touch of the chest wall. If three of these present or any of it, less likely if the patient is having ACS, could be some other diseases there. So after the clinical symptoms come to the most important thing is the ECG changes. In the ECG here we can see what we are what we look in the ECG. It is a J point. J point elevation and depression. It is most important. So as per the guidelines, the ST elevation, which is defined as a new ST elevation of J point in two contiguous leads with a cut point of more than equal to 1 mm in all leads except V2, V3, where the following cut points are applied, like more than equal to 2 mm in men of more than equal to 40 years. If the age is less than 40, then 2.5 mm. In case of the women, it's whatever the age, it is more than equal to 1.5 mm. On the other hand, ST depressions, the new horizontal or downslope with ST depression of 0.5 mm in two contiguous leads, or T inversion of more than 1 mm in two contiguous leads with prominent R wave or R by S ratio is more than 1. This is defined as a ST depression, ST elevations. Say the ECG changes of acute coronary occlusion. Here you can see from the left to the right. Start with the normal ECG, then hyperacute T wave, the minutes to hour, then ST elevation, then Q wave develops in the 1 to 12 hours, then ST elevation with T wave inversion, followed by T wave recovery, but Q wave will persist. In all the areas in the lower part of the image, you can see after the reperfusion, these changes will reverse gradually. Another important is the Sagar-Bosa criteria for the diagnosis of acute myocardial infarction in patient with left bundle branch block or patient having a pacemaker with the ventricular space. They are not physiologically, they will have a left bundle branch pattern. These are normal left bundle branch pattern with the discounted ST segment and Q. These are the normal. Now, what is the Sagar-Bosa criteria? The concordant ST segment elevation is more than 1 mm, more than equal to 1 mm, or ST segment depression more than 1 mm in V1 to V3, or discordant ST segment elevation more than equal to 5 mm. So these are all, these three features has given a points, 5 points, 3 points, and 2 points. And based on that, if it is the whole score more than equal to 3, it has a high specificity of having an acute myocardial infarction, but sensitivity is low. So therefore, Smith has modified it to increase the sensitivity, where he has put into that ratio of ST segment elevation measured at the J point to the R or S wave, whichever was the most prominent. Grossly, if the changes is more than equal to 25% of the preceding R wave or the S wave, it is confirming that the patient is having acute myocardial infarction. Now, with this ECG, we will see that anatomical distribution based on the ECG lead changes, which leads correspond to the which arterial circulation of the coronary artery. So if you go through this chart, you can see that anterior and septal walls correspond to V1 to V6, which is arterial supplies are proximal LED or left main. V1 to V2 is septal, is a proximal LED or septal branch. V2 to V4 is anterior wall, is a mostly LED. V5 to V6 is a lateral wall, is the LCX, and inferior wall is 2-3 AVF, which is supplied by RCA most of the cases, and LCX, and 1 and AVL is a high lateral wall, which is diagonal or proximal LCX. So these ECG changes will help us to find out which artery has been involved. These are the ECG changes, few specific ECG changes in the STEMI that I will go through it, not all of it. Here, you can see this posterior STEMI. I'll come to the next slide. And LCX and right ventricular MI also come to the next slide. We'll see into that. Important that I have to mention about the multivessel ischemia or left main obstruction that can be indicated by ST depression more than 1 mm 6 or more surface leads, coupled with ST segment elevation in AVR, reciprocal changes. It is an indication of multivessel ischemia or left main coronary artery disease. Similarly, in non-ST ACS patients also, we can have certain specific changes like de-winter STT changes. It is also signifying the proximal LED occlusion or severe stenosis. Another important is the Whelan's signs like biphasic T waves in V2, V3, the type A, or symmetrical deeply inverted T waves in V2, V3, which is a type B. So these are the indication of proximal LED occlusion, though it will seem like a non-ST elevated ACS, but they can progress to the STEMI later on. That's why these changes are very significant to remember. Now, based on the anatomical distribution of acute myocardial infarction, I will go through few ECG changes. Like you can see the anterior wall STEMI, which is the higher incidence of in-hospital admission and the mortality. It is significantly anterior wall, which is presented by ST elevation V1 to V6, 1 and AVL, and with a reciprocal change in the opposite leads. Like here you can see the ST elevations are there in V1 to V2, V3, V2, V3, and reciprocal changes are there in 2, 3, and the AVF, the ST depression. Now, this anterior wall is a extensive anterior wall. Here we can see the ST elevation and progress to even involving the V5, V6, which means it is also involving the lateral walls also. Now, next come to the inferior wall STEMI, which is 40 to 50% has a favorable prognosis. And it is 40% of patients of inferior STEMI. Why important? It can be associated with RV infarction, can be associated with the posterior infarction. And 20% of patients with inferior STEMI has a significant bradycardia due to the second and third degree AV block. So what are the ECG changes in inferior wall MI? You can see the ST elevation in 1, 2, 3 AVF and reciprocal changes in the lateral leads like V1 to V3 and AVL. Whether the inferior wall STEMI because of the right coronary artery or left circumflex artery involvement, can be found out from the ECGs. Like ST elevation, if it is 3 in lead 3 more than 2, and T wave changes in lead 3 more than 2, it is more goes to in favor of RC obstruction rather than if it is equal in ST elevation 2 and 3, it's LCX, left circumflex artery involvement. So this is a ECG. Here you can see the ST elevation is in the lead 3 is more correspond to the lead 2. So it is a RC obstruction grossly. So there are lots of other criteria are also there. And this is an ECG where you can see the ST elevation of lead 2 and lead 3 more or less equal. This is the inferior wall MI. It's likelihood having a left circumflex artery involvement. Now, the right ventricular infarct, why it is important? Right ventricular infarct is a very dangerous thing. The high risk of mortality is there. The management is very difficult. So it can be found out like the ST elevation in inferior MI, ST elevation in V1 and ST depression in V2, or ST elevation in lead 3 more than 2. But it should be confirmed after putting the right-sided chest leads like V3R to V6R. Here in the ECG, you can see that this is an inferior MI. Lead 3 ST elevation more than lead 2, and important in V1 and V2 there is a ST elevation. So in this patient, when you put that right-sided limb lead V4R, the elevation is there, which is a right ventricular infarct. Similarly, in posterior MI, it is also 15 to 20%. Most so posterior MI suggested by the following V1 to V3 leads the following changes, like horizontal ST depression is classical things in the posterior MI, and upright T waves, tall and broad R waves, dominant R. There are lots of other things, but most important is horizontal ST depression in V1 to V3, and posterior infarction should be confirmed by putting additional leads, the V7 to V9. Here, this is a patient presented with this. We can see the horizontal ST depression in V2, V3, and when they have put that lateral, more lateral leads like V7, V8, V9, it is showing the ST elevation of the posterior MI. So, until this, we have gone to the ECGs. Now come to the echocardiography. Echocardiography has a very good role in ACS. Focal wall motion abnormalities support the diagnosis of AMI. It can rule out the other alternative diagnosis like aortic dissection, tamponade, pulmonary embolism. Echocardiography will occasionally reveal complications of AMI like papillary muscle ruptures, interventricular septal rupture, pre-myocardial wall rupture, etc. Echocardiography also allows us this hemodynamic assessment. These are the basic echo windows and associated arterial territory, which it shows here. Okay. Now the biomarkers. As you all know, troponin has a greater sensitivity and specificity. Earlier there was a CKMB was used, but not right now. Troponin I can be falsely elevated patient with renal failure, and level of troponin started rising within 3 to 6 hours and peaks about 24 hours and remain elevated up to 14 days. So these are the troponin level. First biomarkers to rise is the myoglobin, followed by troponins and CKB. Now the differential diagnosis of acute coronary syndrome. So they are because the presentation could be the same, like a chest pain. Based on that, our differentials like pulmonary embolism causing a pleural infarct and chest pain would be the subjective pleuritic chest pain. ECG often unchanged, but focus can help us to find it out, and CT angiography. Pulmonary embolism with RV strain with myocardial ischemia also can present with the ischemic chest pain due to hypoperfusion of the right ventricular free wall, and ECG changes could be just like that of classical pulmonary embolism is one Q3 T3 pattern or right axis deviation, T wave inversion. Focus on CT angiograph, CT pulmonary angio can rule it out. Aortic dissection is another important differentials. This patient with the chest pain, sharp tearing pain, rapidly acceleration to the maximal pain. So mostly radiating to the shoulders, may be associated with variety of symptoms. Why it is important in dissection? If you give a loading antiplatelet, patient will die. So though in ECG, usually non-specific, examination finding is very important, like blood pressure differentials between the both the upper limbs, right and left. Focus can help us out, like echocardiography, aortic root dilatation, aortic regurgitation, and others like chest X-ray can give us some clues by widening of mediastinum, and most importantly, if we go at CT angiography, it will be the diagnosis. Other differentials like pericarditis, the characteristics of the chest pain can rule it out, and also the ECGs, pneumothorax like sharp pain and dyspnea, X-ray will rule it out, and pneumonia can also present like an ACS, like if it is peripheral involvement or pleuritic chest pain presentation. Another important is a Takotsubo cardiomyopathy. It is a very important in regards to the ACS. May cause angina, chest pain, dyspnea, arrhythmia, mostly associated with emotional and physical stress. ECG changes ST elevation generally in the first finding, usually V3 to V6, but T wave inversion may follow. Focus will help us in the classical echo findings like apical hypokinesia, but it can only be ruled out after a cardiac catheterization, often needed to explore the MI. Though presentation all looks like a or mostly the antral MI and diagnosis. After this all, after the echocardiography, ECG, biomarkers and all. So what is the management? Here is a flow diagram. You can see like a clinical presentation. You first need to make a working diagnosis based on the clinical presentation, ECG changes, then further investigation like troponins and angiography. And after that, we go to the final diagnosis, STEMI, NSTEMI, unstable angina or non-ACS diagnosis. So this is a picture diagram. It's showing the whole the flow, whole the This is a flow diagram, how to proceed in a patient with ACS. Initial ACS assessment like ECG examinations, vital signs, high sensitivity cardiac troponin levels, working diagnosis, and their further management and further investigations. So we'll go through one by one. So initial assessment, we have an ACS stands for abnormal ECG with the clinical context. Now the patient is stable or unstable. We need to manage. So initial assessment, ECGs, 12 lead ECG, target time is less than 10 minutes of fast medical contact and should be the patient could be kept on continuous ECG monitoring. Additional leads, if needed, like in inferior MI, we know that the RV infarct and posterior infarcts may be associated, may be given for that, or total visual occlusion, or if it is inconclusive, we may need to repeat the ECGs again. Then blood sample, high sensitivity troponin, immediately our target point of to get the result should be within 60 minutes. European Society guideline has put out given a two algorithm. One is 0 hour 1 hour or 0 hour 2 algorithm or 2 hour algorithm to rule in or rule out the nth thing. And if it is not fitting into any of these two algorithms, we need to repeat the cardiac biomarkers again after 3 hours if first two measurements are negative. And after that, we need to try for emergency reperfusion therapy. So these are the guidelines. We can see that the class 1 indication, the combination of clinical history, symptoms, vitals, and physical findings, ECG and troponin should be done. ECG, as I said, the target time should be less than 10 minutes. Continuous ECG monitoring and use of additional ECGs depending on the in cases of infestemi or total vessel, and additional 12 lead ECG recommended in diagnostic answer. All are class 1 indication recommendations. Blood sampling, again the 60 minutes our tag time, two algorithm, 1 and 2. This is a class 1, and also if it is the patient is not fitting in the 0 hour 1 hour or 0 hour 2 hour algorithm, it is negative, then repeat the test after 3 hours and establish the risk codes and triage the patient who will need the emergency or immediate reperfusion strategy. Regarding the end-STEMI diagnosis, there is an important flow diagram. Here you can see if the initial cardiac troponin levels is very low or low initial troponin levels and no increase after 1 hour, 2 hours, it's a rule out pathway. You don't need to think in the whatever non-ST, ACS. But if it is high initial or rise in 1 hour, 2 hours, it's a rule in pathway. We need to triage the patient immediately. Patient will need that immediate reperfusion therapy. And patient who do not meet the criteria for either of the two pathways, we need to repeat it, and then again we need to think about which pathway we need to put the patient. Then the imaging, that already states the transthoracic echo should be routinely available, but it should not delay the primary coronary intervention. Suspected ACS can identify ongoing or past ischemic changes, detect the alternative diagnosis. Cardiogenic shock and mechanical complications has a class 1 indication. Coronary CT angiography, ruling out the alternative changes of ACS like PE and aortic dissection, no role in patient presenting with suspicions of ongoing coronary or acute coronary occlusion. For emergency, invasive coronary angio is a priority, and risk stratify the selected low risk end-STEMI patient which is needed. And cardiac MRI, it can be done. It is mostly helpful in the MINOSA following invasive angiography for assessment of left thrombus. We'll come to that later. So these are the imaging indicator recommendations. So you can see routine CCTA is not recommended, and transthoracic echo is recommended as a class 1 in cardiogenic shock or suspected mechanical complications. Now we have diagnosed the patient. We have to provide some initial management. Besides that, acute management directed to the coronary artery disease. This is our area, mostly the oxygen therapy. The recommendation is that oxygen therapy should only be given to patient with hypoxic, like saturation less than 90, not more than 90. There are two trials there, Detox 2 AMI trial. Routine use of supplemental oxygen in patient with suspected AMI did not have hypoxemia, was not found to reduce the 1 year mortality. Another trial, the AVOID trial, which showed as per the MRI, the extent of myocardial scar was increased who received the oxygen therapy. Next comes the opioid therapy. It is a pain. It should be considered, it is not a class 1 indication, for the relief of pain and tranquilizer for the anxiety. Routine use of opioid does not reduce the mortality. Some limited data are there which suggest that it can diminish the effect of the P2Y12 inhibitors. Like in patient trials, they have found out morphine delays the attenuates at the ticagrelor exposure and action in patient with myocardial infarction. And Crusade Quality Improvement Initiative also use of morphine either alone or in combination with nitroglycerin for patients presented with NCACs associated with higher mortality. That's why morphine is not a class 1 indication, it should be considered with the pain relief only. IV beta blocker, it has been shown as a associated reduction in the incidence of ventricular fibrillation and microvascular obstruction. Metoprolol is demonstrating the greatest protective effect in the experimental studies. This is the most recommended beta blocker in this regards, and it should be given to all patients if there is no signs of heart failure or systolic blood pressure is more than 120 and without any other contraindication. Now come the nitrates. Management of pain due to myocardial ischemia. It is based on the nitrates, improving symptoms of pulmonary congestion, lowering the blood pressure. MI with ICS with high blood pressure, nitrate is better. Is recommended and aiding in the diagnosis and management of coronary artery spasm. But it is contraindicated in someone presented with hypotension, marked bradycardia, we mark tachycardia, RV infarction, because in that case it will lead to the severe hypotension, aortic stenosis, and someone has already received phosphodiesterase 5 inhibitors within last 24 to 48 hours. So these are the guideline recommendation. Here we can see we have already discussed about that hypoxemia, use of opioids is the class 2A and the class 1, and the intravenous beta blocker is also class 2A recommendation. Now, besides the general management, now come to the acute phase management of ACS. Patient with working diagnosis of STEMI, this patient should be triaged for immediate deperfusion therapy. STEMI, there is no doubt, we should go for a deperfusion therapy. Our first priority will be primary percutaneous coronary intervention strategy, or if not, fibrinolysis, if PPCI is not possible within 120 minutes of the diagnosis. Patient with a working diagnosis of non-ST elevated ACS, here for this patient, inpatient invasive strategy is recommended, but all the strategies depending on their risk profile. We'll come to that later. Now come to the ST elevated MI. Here we can see from the onset of symptoms, then mode of first medical contact. Either patient goes directly to the hospital or patient calls the EMS. If it is directly to the PCI center, the PPCI strategy is the first priority. Aim should be less than 60 minutes to the wire cross. If the patient presented to the non-PCI center or ambulance, we have to decide during the transit or in that center whether PCI is possible less than 120 minutes or not. If yes, then we should go ahead for PPCI or transfer the patient to the PCI center, and our aim of target should be less than 90 minutes to the wire crossing, immediate transfer. If it is not possible within 120 minutes, then we should go ahead for the fibrinolysis strategy, where our target timing would be less than 10 minutes to the lytic bolus patient. So if you summarize this presentation, less than equal to 12 hours, reperfusion therapy, we should always consider PCI or fibrinolysis. Anticipated time for diagnosis to PCI, if it is less than 120 minutes, go for primary percutaneous coronary intervention. More than 120 minutes, we cannot do that within 120 minutes, go for fibrinolysis. Presentation more than 12 hours. Here, routine percutaneous coronary intervention is uncertain benefit until and unless the patient is having a ischemia symptoms or instability. And the presentation, if it is more than 48 hours, there is no role of primary percutaneous coronary intervention unless patient is having a symptoms or any other complication. This is the overall in a nutshell. This is the same thing has been given here. So in the guideline, you can see the right hand side, all of the class 1 recommendations. Important thing, I'll go directly to the last one. Rescue PCI is recommended for failed fibrinolysis, where the fibrinolysis has failed, like ST segment resolution less than 50% within 60 to 90 minutes, or in presence of hemodynamic instability, electrical instability, or worsening symptoms. In that case, we should go for a rescue PCI. Okay, these are the recommendations we already discussed in the previous slides. Now come to the fibrinolysis. So our target is what is called the successful fibrinolysis. Target time that we already discussed is less than 10 minutes when we are taking the decisions. Successful reperfusion is defined as significant improvement in the ischemic symptoms, more than equal to 50% ST segment resolution, and patient becomes hemodynamically stable. Initiate the fibrinolytic therapy in pre-hospital setting if our trained medical or allied health staffs are there. In that case, if they can interpret or interpret in the in the remote interpretation. Goal is to start therapy within 10 minutes of diagnosis. Initiation should not be delayed by waiting for the result of biomarker. In case of the STEMI, for the emergency therapy, we should not wait for the biomarker. There is no allowed. Failed fibrinolysis, in that case, we should go ahead for the PCI. Repeat the dose of fibrinolysis is not beneficial. And drugs used for fibrinolysis, always the fibrin specific agents are preferred, like alteplase, tenecteplase, retaplase. These are the fibrinolytic agents that we have. One is the streptokinase. You can see the doses and their consideration: alteplase, retaplase, and tenecteplase. Tenecteplase is a one single bolus dose that you can see uh, based on the body weights. You can use. Now, contraindication of fibrinolysis, where we should not go ahead for the fibrinolysis, like absolute contraindication, mostly the intracranial hemorrhage, a stroke of unknown origin, ischemic stroke within 6 months, central nervous system damage or neoplasm, recent major trauma, surgery, or head injury, preceding month, GI bleeding in the past month, known bleeding disorders, aortic dissection, non-compressible puncture in past 24 hours. And then there are certain relative indications also, like contraindications also, like refractory hypertension, pregnancy, oral anticoagulation therapy, PIA preceding 6 months, liver disease, infective endocarditis, prolonged traumatic resuscitation, and active peptic ulcer disease. Now, after the fibrinolysis, what should we do? Should we wait for the complete reversal of the 60 to 90 minutes of the ECG? No. We should transfer the patient to the PCI capable centers as fast as possible immediately after the fibrinolysis. One. Emergency angiography and PCI of IRA, infarct-related artery, if indicated, are recommended in patients with new onset persistent heart fibrinolysis failure. An angiography and PCI of IRA, if indicated, is recommended between 2 to 24 hours after successful fibrinolysis. In that case also. Now come to the non-ST elevated ACS. These are the STEMI. We have found out we should go for primary percutaneous coronary intervention or fibrinolysis. In case of the non-ST elevated ACS, there is no role of fibrinolysis first. So we should stratify the patient risk factor. Like very high risk NST-ACS patient should undergo immediate invasive strategy with emergency angiography and PCI. High risk NST-ACS patient recommended to go for a angiography and PCI, inpatient invasive, not an emergently, but within 24 hours. For who patient who do not meet any of the criteria for very high risk and high risk criteria, there the strategy should be tailored based on the suspicion. If it is a high index of suspicion, inpatient invasive strategy is recommended. We'll admit the patient and later on we'll go for invasive strategy. The low index of suspicion of NST-ACS, we should do some other imaging like CT coronary angiography, and based on that we can take the next steps. So this is a flow diagram of NST-ACS management. Here you can see the very high risk immediate invasive strategy, other cases inpatient invasive strategy, another is early invasive and the selective invasive strategy. So these are the risk stratification of NST-ACS. Very high risk. Who are the very high risk? The hemodynamic instability or cardiogenic shock, recurrent ongoing chest pain, refractory medical therapy, acute heart failure secondary to ischemia, life-threatening arrhythmias, cardiac arrest, mechanical complications, recurrent dynamic changes in the ECG. High risk was a confirmed diagnosis of NSTEMI based on ESC algorithm. Grace questionnaire is more than 140, transient STT change elevation, and dynamic ST segment and T wave changes. But if the patient doesn't have any of it, it's called the low risk category. So these are the same things has been given as a recommendations over here. You can see. Okay. Now in NST-ACS and STEMI and non-ST elevated ACS algorithm we have gone through. Now the very important thing, what is the role of CABG in acute coronary syndrome? So cardiogenic shock and hemodynamic instability, CABG is indicated to improve survival where the PCI is not feasible. irrespective of the time delay. PCI is not feasible, patient general condition or whatever, you should go ahead for the CABG. Can we go ahead? Patient with ACS and mechanical complications like ventricular septal rupture, mitral valve insufficiency, papillary muscle infarction or rupture, CABG is recommended at the time of surgery with the goal of improving survival. PCI, another case of PCI is not feasible or successful, where the large area of myocardium at risk, you cannot go ahead for the PCI successfully. Emergency or urgent CABG can be effective as a reperfusion modality to improve the clinical outcome. And last category where the complex multi-vessel non-infarct artery diseases like TVD and left main after successful primary PCI. Though the successful primary PCI has been done, but rest of the arteries are not good. In that case, elective CABG is a reasonable option to reduce the mortality. From the reperfusion therapies, now we'll go to the medical therapy. So medical therapies, what we have the antiplatelets and anticoagulants. And antiplatelets, we have three types. One is the aspirin, which inhibits the thromboxane A2 inhibitors. Here we can see. Another one's P2Y12 receptor inhibitors. Among them are the clopidogrel, ticagrelor, prasugrel, cangrelor. GP2B3A inhibitors, eptifibatide and thyroxine. They all inhibit the aggregation of activated platelets, and they inhibit the mature fibrin clot formation over there. And anticoagulants that we have, first and foremost, we have the factor 10A inhibitors like oral anticoagulants, rivaroxaban, apixaban, endoxaban. We can have fondaparinux, can have alpha-actinated heparin, which is the factor 10A and thrombin both inhibitors, and enoxaparin, the low molecular heparin factor 10A inhibitor, and direct thrombin inhibitors are dabigatran and vivalutamide. We'll come to that one by one. Now, antiplatelet therapy. Antiplatelet drugs is a key role in acute phase treatment of ACS. All the patients with ACS should receive the aspirin treatment started with a loading dose as soon as possible, followed by a maintenance dose of 75 to 100 mg once daily. This loading dose usually given is 300 mg. Dual antiplatelet including aspirin and 14p2Y12 receptor inhibitors like prasugrel and ticagrelor is recommended as a default DAPT strategy for ACS. The Plateau trial and Triton P38 have shown the efficacy of it. Where we cannot use the protein P2Y12 inhibitor, we use the clopidogrel, which is characterized by less effective and more variable platelet inhibition, should be used when prasugrel, ticagrelor are contraindicated, like extremes of ages, high risk of bleeding tendencies, where not available or contraindicated. In that patient, we use the clopidogrel. Prasugrel should be always considered in preference to ticagrelor for ACS who going for the PCI, like isoreactor. In patients with a working diagnosis of STEMI undergoing primary coronary intervention, pre-treatment with P2Y12 distributor may be considered. Now, there is a little differences in that, whether you should give directly loading dose in the emergency or not. If my patient is going for a primary percutaneous coronary intervention in non-STEMI patients, it's better if there is no class 1 indication, though we have to give the aspirin loading, but this prasugrel, ticagrelor or clopidogrel loading, it is not indicated as a class 1. It can be given after a coronary angiography. That's why in patient with working diagnosis of NCACS, routine pre-treatment of P2Y12 receptor inhibitors before knowing the coronary anatomy in patient anticipated to undergo early invasive strategy is not recommended, not routinely. But if you are thinking the patient will go for invasive angiography after 24 hours, where it can be given. Why do they don't want to give the P2Y12 inhibitors? Because if the complex anatomy patient needed a CABG, it will be difficult to do that because of the high risk of bleeding tendency if the patient already received the loading dose of these drugs. So here comes the recommendation regarding the aspirin. It's a class 1 indications. All ACS patients should receive the P2Y12 receptor inhibitors in addition to aspirin, given as it's a class 1 indication. All patients who are receiving DAPT should be given proton pump inhibitors in patient with a high risk of GI bleeding. Now, among the all Y12 receptor, prasugrel is first preference, the class 1. Then comes the ticagrelor. Then comes the clopidogrel. If the patient with ACS, if the patient presenting with ACS stop DAPT to undergo CABG, it is recommended they resume DOPT after the surgery for at least 12 months. We need to continue. So here is the GP2B3A inhibitor. That is another antiplatelet that we have not mentioned here, like the tyrosine apixaban. There is no class 1 indication to start that. This receptor antagonist should be considered if there is evidence of no reflow or thrombotic complication during PCI. During the PCI, it can be started as an infusion. In P2Y12 receptor inhibitor naive patient undergoing PCI, cannular may be considered. In older ACS patient, clopidogrel is better considered. So here comes the NCACs and our pre-treatment patients. The pre-treatment with these drugs like P2Y12 receptor inhibitors is a consideration, not a class 1 indication. It can be considered when our invasive strategy has been planned more than 24 hours. And GP2B3A receptor pre-treatment is not at all recommended. It's only recommended when there is a no reflow or thrombotic complication during the PCI. Okay. Now come to anticoagulation therapy. So anticoagulation therapy, parenteral anticoagulation recommended all ACS patients. In case of the STEMI, unfractionated heparin is a default choice. Enoxaparin and bivalirudin should be considered as an alternative to unfractionated heparin, and bivalirudin is also recommended alternative to UFH in patient presenting with ACS with a history of heat. If the patient is having a heat history, so better to use bivalirudin. Another drugs, fondaparinux, though it is directly not recommended, patient who is receiving the PCI, it is not planned for PCI, it can be used. The anticoagulant should generally be discontinued immediately after PCI, except in cases of LV aneurysm or other reasons to requiring the anticoagulation like thrombus formation or AF. NSTEMI patient undergoing immediate or early angiography, unfractionated heparin is recommended, but enoxaparin should be considered and to UFH. Not anticipated to undergo early angiography, fondaparinux is recommended. So overall, we have the 3-4 anticoagulations like unfractionated heparin, we have enoxaparin, we have fondaparinux and bivalirudin. Unfractionated heparin is one of the default choice. There is no specific good evidence onto it. It can be given, or its alternative are enoxaparin and bivalirudin. Bivalirudin, when it's given, it should be given during the PCI procedure as an infusion. And bivalirudin has another indication if the patient is having a heparin-induced thrombocytopenia. Last one is fondaparinux. It can be given where there is no anticipated to undergo early angiography. In that case, fondaparinux can be given. So, what is the primary reperfusion strategy? PCI, UHF, and bivalirudin. Fibrinolysis after thrombolysis is angiography with appropriately PCI is likely. If yes, go for a UFH. If it is no, then enoxaparin and fondaparinux. If no reperfusion therapy is mandated, UFH or enoxaparin. So these are the doses of UFH, enoxaparin, bivalirudin, and fondaparinux given here. So anticoagulation, all should receive the anticoagulation. Class 1 indication, routine use of UFH bolus, class 1 indications. Enoxaparin is an alternative to it. Discontinuation of parenteral anticoagulation should be considered immediately after invasive procedures. Patient with STEMI, mostly they have recommended the UFH, an alternative is enoxaparin. In case of NST-ACS, for patient NST-ACS, early invasive angiography is not anticipated. Fondaparinux is class 1 recommendation, and in whom early invasive angiography, basically very high risk patients or high risk patient, is better to give enoxaparin or UFH than the fondaparinux. So now come to the long-term therapy. What should be our long-term therapy? So here is a chart we can see here. STEMI, NSTEMI, whatever it is. First is anticoagulation in STEMI and yeah, you can see. So class 1 in STEMI patient who is going for reperfusion therapy, UFH is a class 1, then enoxaparin, then bivalirudin, fondaparinux is not recommended in STEMI patient. NST-ACS, less than 24 hours of angiography, UFH, more than 24 hours is fondaparinux. Okay. Routine antiplatelet therapy, aspirin, and P2Y12. Long choice of P2Y12 inhibitors. First is prasugrel. If not, ticagrelor. If both of it not suitable, then go for copidogrel. Duration of therapy of dual antiplatelet at least 12 months, and after that, single antiplatelet. This is the basic strategy. Now, patient with ACS with an indication of oral anticoagulation. The patient already having a oral anticoagulation, or patient have developed LV thrombus, or patient have developed AF. In that case, at least for a month, first we should start a triple antithrombotic therapy. So one oral anticoagulation and dual antiplatelet. It's a class 1 up to 1 week. If the bleeding risk is high, it can be switched to one oral anticoagulation and single antiplatelet till the 6 months. Basically, if my bleeding tendency is not pretty high, after giving a triple antithrombotic therapy, we should switch to dual antithrombotic therapy, which is comprises of oral anticoagulation therapy and single antiplatelet therapy. Should be continued up to 12 months, followed by beyond 12 months only continue the anticoagulation. Okay. If the strategy to reduce ischemic risk, if there is a chances that our other indications where we need to use our ischemic risk is high, where we need to use the triple antiplatelet antithrombotic therapy at least for a month. If the ischemic risk is low, use for a 1 week, then switch to dual antithrombotic therapy. If it is high, switch to the triple antithrombotic therapy for a month, and after that continue the dual antithrombotic therapy just as before, and later on switch to the oral only monotherapy anticoagulation after the 12 months. So in earlier stage, after the 12 months, we are only continuing the aspirin. Here we will only continue the oral anticoagulation therapy. So these are the indications over here. We can see the default strategies where we should, as a default strategy for patient with atrial fibrillation, like the CHAD-VAS score, we should add the NOACs. During the PCI, just a minute. Okay. If someone is a VKA treated patient, if the INR is less than 2.5, we should use the unfractionated heparin bolus. And rest of the others are not a class 1 indication. So overall, we need to follow this strategy. Now, here comes the bleeding risk, where we need to reduce our antithrombotic therapy. So high bleeding risk, it is based on the Academic Research Consortium for high bleeding risk. Here we can see major criteria and minor criteria. One major or two minor is considered as a high bleeding risk. Anticipated use of long-term anticoagulation, CKD, hemoglobin low, spontaneous bleeding requiring hospitalization, chronic bleeding diathesis, cirrhosis of liver with total hypertension, previous spontaneous ICH within last 12 months, traumatic ICH, non-deferrable major surgery, recent major surgery within 30 days before the PCI, and rest of the minor criteria like age, more than 75, moderate CKD, hemoglobin 11 to 12.9 for men and 11 to 11.9 for women. Spontaneous bleeding requiring hospitalization within past 12 months, not meeting the major criteria. Long-term use of oral NSAIDs, any ischemic stroke. So in these cases, we need to think about shortening or de-escalation of antithrombotic therapy. In this patient, there is two ways we can go ahead. One is abbreviated DAPT therapy, another is DAPT de-escalation. DAPT de-escalation, like from potent P2Y12 inhibitors, we will switch to the non-potent, like copidogrel. We can switch, or we can directly, we'll at least continue DAPT for 1 month, followed by we'll only use single antiplatelet for next of the 12 months. And based on this strategy, we will be depend on 1 month, 3 months, or 6 months DAPT therapy. Now, the thrombotic risk, where we need to escalate the antithrombotic therapy, it is depending on your thrombotic risk, like high thrombotic risk or moderate thrombotic risk. These are the list of it. So, and there is a PCI related, our thrombotic risk calculation can be done during that time of angiography. So, if there is a high thrombotic risk, we need to prolong the antithrombotic therapy. Discontinuation of antiplatelet treatment in patient treated with oral anticoagulation recommended after 12 months, and adding a second antithrombotic agent to aspirin for extended long-term secondary prevention should be considered in patients with high ischemic risk. There is no class 1 indication. This area is a gray area where the thrombotic risk is more. We can continue dual antiplatelet beyond 12 months and depending on the coronary anatomy. Now, little bit of technicals about the PCI. What is the indication? Earlier, there was a high risk of bleeding complication during the percutaneous coronary intervention when it was done with the femoral arteries. That's why radial access is recommended. It's a class 1. PCI with stent deployment with infarct-related artery during index procedure should be done. Not all the arteries should be intervened. Drug-eluting stents are recommended, and patient with spontaneous coronary artery dissection (PCI) is recommended only for patient with symptomatic changes. Intravascular imaging should be considered to guide. During PCI, if the anatomy is not very delineable, we can use the imaging. Radial access, only the infect-related artery, drug-eluting stents are the class 1 indication. Rest of the part where the coronary artery bypass graft should be considered patient with occluded IRA. When the PPCI is not possible, you should go for a coronary CABG that we have already mentioned. Just a minute. And another important, the thrombus aspiration is earlier is to do. It's not recommended. You should put a stent on it. Now, regarding this infarct-related artery intervention, here there is a 2 trial. So known as a shock trial. Here we have seen that no difference in mortality at 30 days, but at the 6-month mortality was lower in group assigned to revascularization than in group assigned to medical therapy. What is it? Basically, if the patient is ACS and a cardiogenic shock, we should go ahead for immediate coronary angiography PCI if feasible because it will improve the mortality. If coronary anatomy is unsuitable, go for an emergency CABG. It was as per this trial. Later on, one trial came, which artery to be intervened. So culprit shock trial by infect-related artery only, PCI was associated with significant reduction in all-cause death or renal replacement therapy at 30-day follow-up. Not all the arteries should be intervened, only the infect-related artery. So this is a algorithm. Here you can see PCI of IRA with angiographically significant stenosis of more than one non-IRA vessels. If a cardiogenic shock, immediate PCI of IRA only. Stage completion, stage complete revascularization, class 2A. Even in STEMI patient, complete revascularization either during index procedure or within 45 days. Non in cardiogenic shock patient. And in STEMI also, in STEMI SCS, we can go ahead for the complete revascularization in the index cases. In cardiogenic shock patient, go for a IRA and come out and lateral deal with the rest of the process. Another important entity that has been given here is the MINOSA. This is a symptom suggestive of present with the ACS, where basically it presents like a ACS, demonstrate troponin elevation. It's a non-obstructive coronary artery disease. When you do the angiography, is found out to be as coronary artery stenosis less than 50%. Its prevalence has been found out about 1 to 14%. It's considered an umbrella term that encompasses heterogeneity. Basically, you have an AMI patient, ECG changes, echo changes are there. When you go for an angiography, found out there is no critical stenosis. It's called as the MINOSA. So here comes a need for other assessment like ventriculography, functional assessment, MRI could be done. So this is spectrum of disease. There are lots of reasons for this, like coronary related, coronary embolism, coronary microvascular dysfunction, coronary spasm, coronary thrombosis, myocardial bridging that can cause it. Non-coronary cardiac causes like cardiac trauma, cardiomyopathy, cardiotoxins, myocarditis, tachycardia can present like that. And non-cardiac causes also present like MINOSA, like important in acute respiratory ARDS, allergic hypersensitivity reaction, in-stage renal failure, pulmonary embolism, etc. So guideline is that in patient with working diagnosis of MINOSA, cardiac MRI is a class 1 indication, is recommended after invasive angiography. And management of MINOSA according to the final established underlying diagnosis is recommended. And all patients with an initial diagnosis of MINOSA is recommended to follow and diagnostic algorithm determine. Underlying final diagnosis should be found read out, whether it is a cardiac coronary related or non-coronary cardiac causes or non-cardiac causes. So this is the overall flow diagram for that. Now the complications of ACS that I'll go ahead. The most important complication that in our settings like cardiac arrest, ACS is the most common cause of the out of hospital cardiac arrest. And patient with return of spontaneous circulation who having a persistent ST segment elevation should undergo primary percutaneous coronary static immediate ICI, PCI if indicated. Emergent invasive coronary angio and PCI associated with good outcomes in this setting, particularly in patients who are non-comatose and initial assessment. And patient without ST elevation or ECG, underlying causes are more varied. That's why there is no class 1 indication to go ahead for primary percutaneous coronary intervention in this patient. So routine immediate IC invasive coronary angiography is not superior to delayed invasive strategy based on the data from COAC trial and also the TOMAC trial. The recommendation is like that only. If it is STEMI, ST elevation, go ahead with it immediately, class 1. And routine is not recommended if it is ST segment elevation is not there. Now the cardiogenic shock, early revascularization with PCR CABG is recommended. All patients with AMI with cardiogenic shock based on the shock trial. Surgical revascularization represents valuable treatment if PCI is not possible. AMI related mechanical complications and surgical or percutaneous treatment may also be indicated. So basically, cardiogenic shock with AMI, we should go ahead for a reperfusion as early as possible, either PCI or CABG or surgical, whatever it is. Now, in cardiogenic shock, important the IVP shock 2 trial. The IVP was used in this trial, but didn't show any mortality benefit. That's why it is not recommended in all cardiogenic shock, but it can be used in patients with mechanical complications. Now, to come to the mechanical circulatory devices in AMI setting, it's still not well established, but recent few trials have shown some positive evidences like ECMO cardiogenic shock trial, where it showed, though no benefits, of initiation of VA ECMO in patients with rapidly deteriorating or severe cardiogenic shock. But there was a crossover around 40% because the patient on the conservative arm, around 40% had switched, has been later on switched to that ECMO group. That's why the data, though it is showed did not improve, it cannot be, it is not very reliable in this. ECLA shock trial, it's earlier it was done in 2023. Here is also an acute myocardial infarction complicated by cardiogenic shock. The incidence of death from any cause at 30 days was not lower with early unselective use of VECMO. Crossover was around 12%, was a conservative arm, again crossover 12%. So the data based on the MCS devices like ECMO is not very robust, not very clear over here. Another recently came up trial like danger shock trial where they use a microaxial flow pump, the LVAT, in STEMI related cardiogenic shock. It has showed the lower risk of death and 180 days, but with the incidence adverse effects of higher. It has showed some positivity. So recommendation of cardiogenic shock, the reperfusion should be done as fast as possible. If PCI, IRA is recommended class 1. If it is not possible, PCI, emergency CABG. In case of hemodynamic instability, emergency surgical catheter-based repair of the mechanical complication is recommended. Okay. And regarding in patient with ACS, severe refractory shock, short-term mechanical circulatory support may be considered. It is not a contraindication, it may be considered to be class of recommendation. Routine use of IVP in ACS is not recommended. Now let's come to the long-term therapy. Among the antiplatelet and anticoagulation, we all know about the another important thing is the lipid lowering agent. Lower LDL-C levels are associated with lower cardiovascular event rates. Our secondary prevention treatment goal should be less than 55 milligram and to achieve more than 50% LDL-C reduction from the baseline. In second, if the patient is having a second cardiovascular event, in that cases within next 2 years, the target should be little more stringent. LDL-C level should be less than 40%. In all the cases, high intensity statin, atorvastatin or rosuvastatin initiated as early as possible after hospital admission, preferably before planned PCI. So when you're giving the antiplatelet, you should give the statins also prescribed up to the highest tolerated dose in order to reach LDL-C goal. And lipid level should be re-evaluated after 4 to 6 weeks. This is a algorithm showing lipid lowering drugs. Here we can see high intensity statin therapy should be given Our target is less than 55 with the first cardiovascular event or less than 40 for the second. If it is not controlled with the statins, we should add an ezetimibe. If it is not controlled with the ezetimibe and statin, we should consider adding PSK9 inhibitors. This is in a nutshell. After 4 to 6 weeks, again follow the same algorithm. So these are the guidelines and class 1 recommendations. I already told you in a nutshell. Now, other therapies like beta blockers are recommended in all ACS patients with ejection fraction less than or equal to 40, regardless of heart failure symptoms, class 1. Routine beta blocker, all ACS patients, regardless of LVF, should be considered, though it has a better remodeling effect, anti-remodeling effect, but not a class 1. But if EF is low, you should start. RAS system inhibitors, ACE inhibitors or ARB should be started with EF less than 40%, diabetes, hypertension, or CKD. Mineralocorticoid and antagonist against the same indication, EF less than or equal to 40, heart failure, and diabetes. Routine ACE inhibitors for all ACS patients, regardless of EF, should be considered. There is no clash. Now, last topic will be the complications of AMI. In acute myocardial infarction, the complications would be classified as ischemic complications, pericardial complications, thromboembolic complications, electricals, and mechanical. So we'll go one by one. So this is the guidelines have shown that complications of ACS, if the patient is heart failure, IVP could be tried. But in cardiogenic shock, routine use not recommended. If it is an LV thrombus, MR imaging should be considered and anticoagulation should be started at least continued for 3 to 6 months. In patient with atrial fibrillation, who is hemodynamically, when the rate control is needed, consider beta blocker in the absence of heart failure hypotension. When in presence of heart failure but no hypotension, go for a amiodarone. So AF with heart failure with no hypotension, go for a amiodarone. AF with without heart failure and hypotension, if the rate control is concerned, go for a beta blocker. And immediate electrical cardioversion, if it is atrial fibrillation with hemodynamic instability, when adequate rate control cannot be achieved promptly with pharmacology treatment. Okay, and intravenous amiodarone is recommended to facilitate electrical cardioversion or decrease the risk of early recurrence. Even after cardioversion, you can use that before that amiodarone, so that the recurrence will be less. And obviously, just like the chat scoring system, we should add the anticoagulation. Ventricular arrhythmias. Here the recommendation of the class 1, I have only put it. ICD therapy is recommended to reduce sudden cardiac death in patient with symptomatic heart failure and ejection fraction less than 35% despite optimal medical therapy more than 3 months or at least 6 weeks after MI who expected to survive more than 1 year. Survival should be there and they are not improving even after 3 months and heart failure. Intravenous beta blocker amiodarone treatment is recommended for patients with polymorphic VT or VF. Unless contraindicated, we should treat with this. Prompt and complete revascularization recommended to treat myocardial ischemia that may be. If the patient comes with the ventricular arrhythmias in the ACH, we should go for an early revascularization, manage initially with the beta blocker amiodarone, and later on, if the heart function is low, even after therapies for more than 3 months and heart failure, go for ICD. Similarly, is a bradyarrhythmia patient like bradycardia. So, patient with hemodynamic instability or high degree AV block, initial cases go for a positive chronotropic medications like adrenaline, atropine. Even if not responding to that therapy, go for a temporary pacing in case of failure to respond. And urgent angiography should be considered in all those patients not achieve previous reperfusion therapy. Implantation of permanent pacemaker should be considered with high degree AV block does not resolve within a period of at least 5 days after MI. And in selected patient with high degree AV block, with the context of anterior MI with heart failure, early CRTD and CRTP may be considered. Pacing is not recommended who has recovered from the high degree AV block. So basically here, initial positive chronotropic agents, then if not temporary pacing, go for a reperfusion therapy. And after that, if the block is persisting more than 5 days, at least for 5 days, go for a pacemaker. In anterior MI with a high degree AV block, can consider CRTD or CRTP, but if the block has recovered, may not be needed any pacing. Mechanical complication, these are the list you can see: papillary muscle rupture, ischemic mitral regurgitation can happen. Typically 7 days post-MI. Most commonly clinical presentation will be pulmonary edema, respiratory distress. Most commonly involve artery and right coronary artery. Chest X-ray and echo will be help us to find it out. Management will be acute medical therapy and surgical intervention to mitral valve repair. Ventricular septal rupture, high attained risk initial 24 hours. Secondary peak happens after 3 to 5 days. Symptoms could be chest pain, heart failure, and cardiogenic shock. Echocardiogram is very important to confirm the diagnosis and also the size of the rupture and plan for the next therapy. Medical therapy, hemodynamic support, ventricular surgical intervention is needed. And here we can use IABP and ECMO even in the papillary rupture for the temporary stabilizing before the surgery. Ventricular free wall rupture is very dangerous complications. Type 1, sudden tear within 24 hours. Type 2, gradual tear. Type 3, perforation after 7 days. So symptoms could be chest pain, restlessness, and shock and crash cardiac tamponade. So addressing first tamponade management, shock management, and surgical management. The 3 things should be given. Here the ECMO or IBP can be used. True and pseudoaneurysm, usually within 2 weeks of post-MI, pseudoaneurysm symptoms will be chest pain, dyspnea, cardiac tamponade features will be there. True aneurysm usually manifests as angina, heart failure, ventricular tachycardia. So echocardiography transfer is very important. You can find out the differentiate between the pseudo and true aneurysms. And based on that, pseudo aneurysm usually needed a surgical direct closure, and true aneurysm anticoagulation, wait and watch can be considered. But if it is a large one, we should go ahead for the surgical resection during CVT. Beside cardiogenic shock, we have already discussed, and right ventricular myocardial infarction. Again, we should go ahead as per our ECS protocols. Atrial tachyarrhythmia, ventricular tachyarrhythmia, and bradyarrhythmia. We have already discussed about that. Now, post-infarct angina, this is ischemic complication. Suspicion of recurrent infarction can happen within 18 to 24 hours post-MI. Recurrence of chest pain, heart failure, and hypotension. STT changes could be find out and go for PCI or revascularization if needed. Pericardial complication, that is another important. Post-infarction pericarditis, early, initial 4 days after AMI, or Dressler syndrome, usually it happens after 1 to 2 weeks of post-MI. ECG changes like upright T wave, new onset positive T waves, troponin inflammatory markers may be raised. Early post-infarction pericarditis treated with aspirin with increased doses like 8 to 12 hourly. Late pericarditis, aspirin until symptomatic improvement. Thrombotic complications, systemic or LV thrombus, most frequently with initial 10 days of post-MI. So here we can go for echocardiography and cardiac MRI, find out the thrombus. Main goal of therapy is anticoagulation. So this is the end of the all total of our presentation over here.
Yes, sir, it was a wonderful presentation and the class. And any question from the aspirants? So we have a question in this
First
chat
slide of the
box.
presentation. Where is the slide box? Yeah.
So we have one question in this chat box. It
Okay.
is,
Let me
how should
see it.
pharmacotherapy be adjusted for elderly patient with ACS to minimize the risk of adverse effect due to polypharmacy?
So in elderly with adverse effect due to polypharmacy, first of all, in elderly patients, we should always this antiplatelet therapy in ACS, we should give the aspirin, obviously, in acute phase and also later on. We have a point to be noted, which type of P to Y12 alpha, that is whether we should start a prasugrel, it is not recommended in this patient, ticagrelor or the clopidogrel. So usually as a class 2A indication, you can see that we can consider the clopidogrel in elderly patient. And the patient who have a polypharmacy, we should always think about when you are prescribing the medication, what are the other medications the patient is on. You should think about the interactions onto it and the timing. We should make the timing conducible for the patient so that he or she cannot miss the doses of antiplatelets. This is very important. Like the patient, if we give some odd timing, they will forget. If they forget the taking the antiplatelets, the patient if has already undergone the PCI and regulating stent, whatever stent has been done, it will get blocked very easily. So therefore, with respect to the elderly, the first one choice should be better to consider the clopidogrel to minimize bleeding risk. One, and the timing of the drug should be conducive for the patient. Two, third is we should look at for the interaction. What are the other medication patient is taking? Whether there is a definite interaction with our antiplatelet therapies in this patient or not. Okay. The next question.
The next question we have here is, what is the role of PCI if there is bacteremia, pneumonia, UTI, meningitis?
Okay. What is the role of PCI if there is bacteremia, pneumonia, UTI, and meningitis? Now, see, the most important thing is that if in ACS, first we need to make a working diagnosis. That is as per the algorithm. My patient is having a ACS and if it is a STEMI. Next point will be whether ST elevated or ST not elevated. If it is ST elevated, whatever may be the reason, we should go ahead for the reperfusion therapy. If it is not ST elevated, we can wait, we can stratify the patient. Mostly dual problems like patient is having a bacteremia infection over what I see in that here with an ACS leading to STEMI is not very common. Mostly this patient can have the demand mismatch, demand supply mismatch, that is the type 2 MI, or can present with end-stage. So in these patients, we can continue with the dual antiplatelets and observe. Or if there is a class 1 indication of like a ST elevated, we should go ahead for PCI or other revascularization therapy. And otherwise, we can wait with the conservative therapy. Okay.
So next we have here is, what is the treatment of early stent thrombosis before recent?
What is the treatment of early stent thrombosis before restenting? So now the question is very important. Early stent thrombosis, why it will happen? Your ischemic load is pretty high, or your coronary anatomy is not was suitable for that, and you have missed the antiplatelet dose. So early stent thrombosis, here we should, if it is the early stent thrombosis, we should go ahead for the invasive coronary angiography. Before that, if needed, we need to go ahead for preloading with the antiplatelet again along with the anticoagulation therapy.
Okay, sir,
Okay.
that what we all had. And about the aspirants asking how can they get the PPTs and for the revision, we will provide everything within 1 week.
Okay. Okay. Thank
Okay.
you.
Thank you, everyone. We'll see you in next class. Well, Happy New Year to you.
Happy New Year
Thank
to
you.
everyone. Thank you. Good night.
Good night, sir.